So I want to thank you all for inviting me. The first thing we're going to do is dim the lights because I'm talking about ultrasound, and ultrasound tends to occur in the dark. So you need to learn to live in a low light condition. Particularly up here, you see, when you go to radiology, you see the radiologists sitting in these dark rooms, and they come out and they're squinting. And, you know, some of us as physical medicine doctors are like that, too, because we spend all of our time doing ultrasound. So as I was introduced, technically I'm a pediatric physical medicine. First of all, are you guys physiatrists or physiatrists? I always have to ask this question about, you know, whether I'm being politically incorrect to say physiatrist, because I grew up medically in Ohio, and we're physiatrists there. So, you know, I'm going to say physiatrist, and if I'm offending anybody, I'm sorry. And I'm a pediatric physiatrist, but I spend at least 50 to 60% of my time treating adults. And people think of me also as in the neuro field, but I also spend a significant percentage of my time in the musculoskeletal field. And I think that many people, when they think about ultrasound applications in physical medicine, really think about it for MSK applications. Tendon problems, joint problems, procedural guidance for MSK applications. But really there's a big need for this in the neuro side of our field as well. And I sort of shifted my talk when Stephanie and I initially talked about me coming up. I was going to talk about ultrasound guidance for chemodenervation procedures, which is a big part of what I do. But I wanted to expand that to talk really about ultrasound applications in neuro-rehab. And I'm not trying to do this to exclude the MSK side, but I just couldn't do that in an hour. So these are my disclosures. And I already mentioned that, you know, so ultrasound is really a great application for both MSK and for neuro-rehab. And in both of those fields, it can be used for diagnostic imaging or for procedural guidance. And I want to talk about both of those things, but really mostly on the neuro-rehab field. And talk a little bit about how ultrasound imaging sort of changes my practice, or has changed my practice, and my ability to approach patients, and because it's really useful as an extension of the physical exam. It's not just an imaging technique. It really is an extension of your exam. I use it every day for diagnostic imaging and every day for procedural guidance. So it's a big piece of my practice. NIH, if you're not familiar with the NIH, is a large institution, maybe not quite as spread out as Hopkins or as rabbit-warreny as Hopkins. You guys are hard to find and hard to find your way around, but we're located inside of a big fence because of security issues after 9/11. But there are, I think, 60 different buildings on campus, and the NIH Clinical Center, my first slide, is the largest brick building, fun fact, largest brick building in the world. And of those 27 institutes, if all the patients come to NIH, our research come with some type of research problem. They are entered into a research study, but some of those studies are management of clinical care, so we may have natural history studies that patients come in and we follow over time for clinical problems. And within all those institutes, like the Eye Institute, Neurology Institute, Heart, Lung, and Blood, Cancer Institute, we have all these patients. There has to be a hospital that takes care of those patients, so there's a clinical center. The clinical center functions in a hospital just like, well, not just like any other hospital, but we have all the departments of any other hospital, including rehabilitation medicine, which is where my office is. I run the motion analysis laboratory within rehab medicine. We conduct our own independent research, and we in rehab medicine and we in my lab provide support to other protocols, but we also run our own independent protocols. And with that, we see patients with musculoskeletal problems, we see patients with neurological problems. And if you're an MSK person, you really need to understand neurological problems, and if you're a neurological person, you need to understand MSK issues, because patients don't know that they're only supposed to present with one thing or another. You know, we see patients all the time who present with what's thought of as a musculoskeletal problem when really they have a neurological problem. And I'm going to show a video of this. So my example here is a patient who has a task-specific dystonia. This patient presents with an abnormal gait and running and is referred to 20 different orthopedic surgeons and a physical medicine doctor, and eventually gets either to a movement disorders PM&R doctor or a movement disorders neurologist and is diagnosed with runner's dystonia. Or in my CP world, an adult with cerebral palsy who has horrible hip pain. And everybody thinks, well, they just have hip pain because they have CP. But the person really has femoral acetabular impingement syndrome as a result of mild lateral luxation of their hip. And so you need to be able to go back and forth between these different fields and not just exclusively silo yourself into one field or the other. If you're going into sports medicine, you still need to know neurological problems. And if you're going into a neurological field, you still need to understand musculoskeletal disorders. So that's sort of my soapbox about why we need to do this. So this is a video of a patient that was referred to me with an abnormal gait. And as I said, she's a 45-year-old long-distance runner who's been running for many, many years. And those videos show task specificity, so you can see that when she walks forward, she's got this abnormal, come back here. She can't flex her knee, right? Her right knee is stiff. And everybody, they looked at her knee. She had an MRI of her knee. Somebody aspirated her knee. She had steroid injections in her knee. And if you notice, when she walked backwards, her gait was normal. So she came to us and we said, you have runner's dystonia. And the treatment of this largely is her neurological exam otherwise was completely normal. Her MRI imaging was completely normal. This is a disease that's a software issue, not a hardware issue. This is 4 weeks after botulinum toxin injections in the rectus femoris. And you can see the before and after how much better she is. She was able to go back to running. But she'd spent 5 years not being able to run first and then not being able to walk correctly and had to change her occupation. She was a flight attendant and couldn't work and was on disability because she hadn't been diagnosed. And because the people in MSK had never heard of runner's dystonia. And I presented her case at a Teach the Teachers course at the PM&R, and also brought another patient of mine, a runner, who I have no idea what's wrong with this guy, and brought him into the MSK people because I don't think he has runner's dystonia, and we were trying to figure out from a musculoskeletal side what is wrong with this guy. So we both learn from one another. So this is sort of my example of why you need to know both things. So I'm going to focus just on the neuro side and talk a little bit about diagnostic imaging and procedural guidance, and talk about evaluation of peripheral nerve and muscle. I'm not going to talk about joint and tendon. And then for procedural guidance, I'm going to limit myself really to chemodenervation, other than briefly mentioning intraoperative ultrasound, which I also do. So what about this diagnostic applications? So we use ultrasound increasingly for evaluation of peripheral nerve disorders, including inherited or acquired generalized polyneuropathies, entrapment neuropathies or masses or tumors. There's a large field now of evaluation of ultrasound, including normative databases for nerve size, conduction velocity, sonoacoustic appearance. The diagnosis of, for instance, carpal tunnel syndrome can be established with ultrasound imaging. You can evaluate for masses or tumors. And then for neuromuscular diseases, looking at both primary and acquired disorders of muscle. And I see kids who have congenital muscular dystrophies or other muscle disorders. And I also see probably the largest group of patients that are followed with late onset Tay-Sachs disease who develop abnormal muscle and we're studying these patients and selective weakness in these patients as well. So all of these things can be looked at with ultrasound. So I'm going to look at a few of these things, including entrapment neuropathies, masses, and then neuromuscular, focusing more on the congenital muscular dystrophy, a case study on these. So for peripheral nerve disorders, again, I said, probably the most common entrapment neuropathies are median nerve at the wrist, or carpal tunnel syndrome, and cubital tunnel syndrome for the ulnar nerve, but also radial nerve as well. And we have available data that can help us with ultrasound provide quantitative measures of peripheral nerve enlargement, sonoacoustic properties that can complement the sort of gold standard of EMG or electromyography, nerve conduction testing. And it really is a useful extension to your exam. For instance, in a patient here, this is a patient that was referred for a palmar mass. And full disclosure, this was actually me. I had this mass in my hand for a while, and I was going to go get it taken out, and I ultrasounded it with a standard ultrasound machine, and it looked like a ganglion. And then I was teaching at a peripheral nerve course using a very specialized ultrasound machine that has the transducers go up to 70 megahertz, which the resolution is like 1 or 2 microns for this thing. So what this thing actually was a schwannoma in the palmar cutaneous branch of the median nerve. So if I'd had this thing taken out, I would have had a patch of numbness in my hand as a result of excising this peripheral nerve rather than excising just the schwannoma. So Jeff Strakowski, I ended up having this thing taken out because we have to write a case report about the use of the high-frequency ultrasound machine. And it was the MRI imaging, which was part of the protocol to get this thing taken out, said that it was a ganglion. And the pathology was schwannoma, and the ultrasound said schwannoma. So sometimes ultrasound is more accurate than MRI. It's certainly less expensive than MRI. It costs about $150 to do an ultrasound, and it costs several $1,000s to do an MRI. And the MRI wasn't particularly useful in this situation. So let's look at it.
That's not what it takes to publish it.
No, I know. But you know, they made me get it taken. Well, they didn't make me get it taken out. But if you know Jeff Strakowski at Ohio State, he's very persuasive. And he said, "No, we really need to get this thing taken out so we can prove it's a schwannoma." So I did. I was compliant. It's the only time I was compliant about anything. So what about carpal tunnel syndrome at the wrist? Why do you need ultrasound? We've got nerve conduction testing. EMG isn't particularly helpful, but nerve conduction testing. I mean, we know, slowed conduction across the, carpal tunnel. So, you can come up with lots of good diagnostic imaging. But what that doesn't show you is variations. So what ultrasound adds for you is things like looking at a bifid median nerve or persistent median artery that you can't tell when you're doing nerve conduction testing. It also can show things like a lipoma that's actually the cause of the carpal tunnel syndrome rather than entrapment within the, under the transverse carpal ligament. This is actually extrinsic compression of the median nerve from a lipoma. And if they'd gone in there and released her carpal tunnel, especially endoscopically, they wouldn't have seen this thing. If they'd done an open release, they still might not have seen it because it was asymmetric to the nerve. So it really does provide this additional benefit to the standard nerve conduction testing. And another problem with crowding of the median nerve is intrusion of the flexor digitorum superficialis within the carpal tunnel, that the muscle fascicles actually extend more distal than is normal. And when you flex your fingers, the muscle actually intrudes into the carpal tunnel and entraps the nerve. So there's a whole bunch of different things. With ulnar nerve, you can do dynamic imaging of the ulnar nerve, doing subluxation maneuvers, and prove that the nerve is either subluxing or not in a patient that you think has cubital tunnel syndrome. So it really does provide this additional benefit. What about other unusual peripheral nerve entrapments? So everything I do is or almost everything I do is unusual at NIH because nobody has sort of standard things. So I work on a study of patients with melanostosis, which is a rare proliferative bone disorder that leads to osseous enlargement of a number. It can be any bone in the body, and in some people it's regional, some people it's very localized. But this was a patient who had melanostosis in her tibia, in the anterior tibia, and also in her fibula. And she had a many-year history of neuritic pain within the distribution of the saphenous nerve. And I work in the EMG lab as well as the gait lab at NIH, and the neurologist that did her nerve conduction testing suspected a saphenous nerve entrapment from this bony enlargement of the tibia distally, but the nerve conduction testing was totally unrevealing. She couldn't even find the nerve because of all this bony enlargement. So we went and did an ultrasound on her, and we were able to show, this is actually, I was able to track the saphenous nerve from proximal to distal and show this local area of enlargement of the saphenous nerve. It should be about 1/10 that size of that nerve. When a nerve gets entrapped, it gets enlarged proximally. So we were able to measure this, and then I ended up doing a nerve block. So I did an ultrasound-guided lidocaine nerve block, and her pain went away for the first time in 7 or 8 years. I wasn't able to, sometimes you can hydrodissect these things. You can go in, and just lift the nerve or the bone away, but she was so surrounded in hard calcified bone that I couldn't do this. So we sent her to a plastic surgeon and orthopedic surgeon who essentially tunneled this nerve out and gave her pain relief. So the ultrasound, the electrodiagnostic testing we knew what the problem was, but the EDX testing wasn't helpful, but the ultrasound really gave us this additional piece of information. So in entrapment neuropathies, it's really useful to add as an extension of your electrodiagnostic testing. I'm not saying it replaces it, it's an extension of this. And then what about masses? I mean, I think probably, even if you're not used to seeing ultrasound images, and when you first start doing ultrasound or looking at ultrasound, everything looks gray and white or gray and black. Just like when somebody told you when you did EMG for the first time that this was a fib or this was a positive sharp wave, and you're like, yeah, right. The same thing with ultrasound. You train your eye to see these things, but I don't think that it takes much training to see this giant mass, sort of a mixed echo texture mass of gray or white, and you can see this is the nerve on either side of this. This is you can see a mouse. Oh, you don't see your mouse? I'm sorry. Is there a rat? So you got a pointer? I'm sorry about that. I've been pointing at things all along. All right. That thing is a mass. This is the skin. So superficial is the top of the image. Deep is at the bottom of the image. And this is an imaging of the fibular nerve, right? And this is this giant mass within the fibular nerve. And this is a more distal. This is a long axis view, extended field of view image, so I could image the entire length of the nerve. The ultrasound machine stitches the images together to give you this extended field of view because this was a 13 centimeter long tumor. So this is a patient with neurofibromatosis 2, a known diagnosis. And this is a rare disease, or relatively rare, autosomal dominant, but it's a curious disease in that you actually have to have 2 copies of the gene to be symptomatic. So you inherit one or have a spontaneous mutation, and then later in life develop a somatic mutation in the other gene chromosome, and then develop this condition. And these people develop multiple schwannomas, typically in the acoustic nerve, and they're deaf, but then in all these other peripheral nerves. So her neurosurgeon referred her to me because they were going to do a tumor resection, but they wanted to know what the extent of the lesion was and wanted to go from there. So I did preoperative imaging to show the sites for the incision for them, and then intraoperatively went in and helped them with a dissection using ultrasound, and it reduced the benefit of the ultrasound is it identified additional schwannomas that hadn't been picked up in other portions of the more proximal portion of the fibular nerve, and also distally, that they wouldn't have excised if we hadn't had the ultrasound imaging. And then intraoperatively, rather than taking her in and out of the MRI scan, having to wait having to wait for the one OR with an intraoperative MRI, we were able to do this in another OR and reduce the MRI time, it just sped up the surgery procedure significantly. So those are peripheral nerve things. What about neuromuscular diseases? So I am a pediatric physical medicine doctor, and so I see people that are not only adult patients that are referred for funny-looking gaits to me, but this is a little guy that the physical therapist called me up and said, I have this kid with a funny gait where you do Botox injections. And I said, well, I've learned. I've been in practice long, and I've said, send me a video because, I wanted to see what this was. So you can see this kid, he's very weak, right? He doesn't have spasticity. He can't get up from the floor. And, he uses a modified Gower maneuver to get up from the floor. When he stands in this lordotic posture. And, he has this very, this appearance of an abnormal gait, but appears weak. He does not appear, I think we'd all agree, doesn't appear that he has spasticity, right? His motor control is really good. That's not the issue. The issue is primarily weakness. His history was completely unremarkable from a medical standpoint. His speech and cognitive and fine motor skills were normal, but he had gross motor delays. He had not started walking till he was about 18 months old. And on exam, he had no evidence of facial weakness, but he had significant proximal girdle limb weakness, more so than distal weakness, and was areflexive in both the upper and lower limbs. So this pointed us in the direction of this kid has some type of neuromuscular disease or peripheral nerve problem, but more likely a muscle disease. He also had a significant muscle atrophy. So we did, as an extension of our physical exam, at bedside when the patient came in, ultrasound imaging. And it was to guide further evaluations, as we do this on all the patients that come in. And we did 2D imaging, and the thing that was most apparent, if I can see here, let's see if I can get this. The other button. So this is a short axis view of the thigh posteriorly. So for you not used to looking at these images, top of the screen is superficial, bottom of the screen is deep. This is lateral and this is medial. And this is the images of the hamstrings in short axis. And this is the biceps femoris. This is the semimembranosus. And right here is the semitendinosus. Normally, muscle has this sonoacoustic appearance of a mixed dark or hypoechoic image mixed with, in short axis, a speckled appearance of the intramuscular connective tissue, which is more reflective of ultrasound, so it's brighter or hyperechoic. And so if you look here, he's got this, the semitendinosus looks relatively normal, but if you look at the other two hamstring muscles, the biceps femoris and the semimembranosus, the muscles have this sort of uniform white appearance or high echo white appearance. And that's because these muscles are more selectively involved than there's selective sparing of the semitendinosus muscle in this patient. This is a posterior view of the erector spinae muscle, and there's essentially no muscles. All you're seeing is skin and this tiny little bit of muscle of erector spinae. So this appearance of the profound atrophy of the erector spinae and selective sparing of the semitendinosus sort of pointed us in a direction of what the diagnosis might be, based on ultrasound, not based on clinical history. And rather than sending this child for a muscle biopsy or whole exome sequencing, we got a CK level and a single gene mutation analysis for laminin AC congenital myopathy, because that's what we suspected based on this ultrasound appearance. So we saved the patient a muscle biopsy, and the mutation was positive for laminin AC congenital myopathy. And the first thing is that we saved the patient an invasive procedure. And we were able to immediately get the patient into referral to a cardiologist, because these patients have a high risk of cardiac problems. And we're able to counsel the family about this as well. And so it really, it's better for the patient because there's less invasive procedures that are done. For instance, you can do muscle imaging with MRI, but in a child that's 21 months old, you would have had to sedate him. And the risk for that in a kid with a neuromuscular disease is pretty high. So this was, I think, a great addition for him was the use of ultrasound to help establish the diagnosis. So what about, I'm going to move on to procedural guidance, which, people have probably heard some of my talks before about this at some of the meetings. But so why should you consider, and I'm only going to talk about chemodenervation procedures. I'm not going to talk about joint injections or aspirations. I'm not going to really talk about musculoskeletal applications because the time doesn't really allow. So, but why should you consider this? We have other guidance techniques that we've used for years. EMG and E-stim are both useful for isolating muscles. But my first question for everybody is, how many of you use anatomic guidance when you're doing toxin injections? How many of you do toxin injections? So anybody that does toxin injections uses anatomic guidance. Because if you don't know anatomy, none of the other guidance techniques are going to help you, right? I mean, EMG isn't going to help you if you don't know where the muscle is, right? E-stim isn't going to help you if you don't know where the nerve is. And ultrasound certainly isn't going to help you if you don't know cross-sectional anatomy. So the basis upon which all of the other guidance techniques that we use for these injections is really our knowledge of cross-sectional anatomy and functional anatomy. You need to know that the flexor digitorum superficialis flexes at the proximal, at the PIP, not the DIP, and that it's the FDP that flexes at the DIP. But that when you flex the DIP, you're going to see movement in the FDS as well because the tendons are moving together. You know, you can't not move one without the other. Or functionally, if you think about foot inversion, so you have a patient that has equinus, a kid with cerebral palsy, an adult with stroke, somebody with TBI, and the patient presents with equinus either in one foot or both feet. And you need to know that it's not just the tibialis posterior that causes foot inversion, that the tibialis anterior is also an inverter of the foot, that the flexor digitorum longus, anything that crosses the medial ankle can invert the foot. And so you need to have that knowledge of anatomy if you're going to do these injections. But beyond that, we've been using EMG and e-stim for years. Why use ultrasound? Well, particularly for chemodenervation, we know that accurate targeting is important. It's important for safety and minimizing risk. The issue of targeting errors and causing unintended weakness in untargeted structures, or procedural adverse events that you inject the wrong thing, or medication side effects. I mean, the side effects, particularly of toxins, is generally weakness in adjacent structures or distant structures, and you want to minimize this. And what about procedural effectiveness? Not only if you target the wrong muscle, not only are you going to get weakness in the muscle that you injected that wasn't the target, but you're also not going to get any effect in the target muscle because you're not in the target muscle. We're all about trying to be precise about where we put things. And potentially one of the things we're looking at right now in a study is, does the use of ultrasound reduce the required effective dose for toxins? Because if you're more precise in placement of the toxin, does that reduce the dose that's required? And because you're not relying on diffusion of the toxin to the target structure. So there's lots of different reasons. And then for phenol, the same thing. For phenol or ethanol alcohol blocks for either motor point blocks or nerve blocks, you really want to be precise when you place that toxin that agent, because it causes denaturation of protein. If you're running the wrong site, you're going to cause damage rather than a nerve block. So what does ultrasound provide for us? It gives us information about complex, deep, overlapping muscles. It shows us the length of the muscle, the position of the muscle, and a safe path to the target. You can identify individual muscle fascicles, and you look at anatomic rearrangement. So I was going to just look at all of those little aspects. So one of the things when you start looking at ultrasound, and I sort of put this anatomical image with the ultrasound superimposed on it, all of ultrasound imaging is, for muscle is based on pattern recognition. So there are certain muscles that have certain sonoacoustic properties, and based upon that, you identify that structure and then the surrounding structures based on contour lines, adjacent structures. So for instance, in this view here, I hope you can see it's labeled, which is nice. Unfortunately, the ultrasound machine doesn't label the images for you. You actually have to learn what they are. So that flexor carpi radialis has this characteristic sonoacoustic appearance of this little nose that it wraps around the underlying pronator teres. So on this image, medial is screen left and lateral is screen right. This is a short axis view. And this is the skin. This is the flexor carpi radialis. Just medial to that, in this person, is the palmaris longus muscle. Just lateral and deep is the pronator teres. And just deep to the flexor carpi radialis in this image is the flexor digitorum superficialis. And below the FDS is the FDP. And it takes, once you know this image and this pattern, you immediately can identify these structures and very quickly inject and target these muscles. So I'm going to talk a little bit about some of the advantages besides just this anatomy. I'm going to go through all of those things we talked about, but one of the things that is really important for chemodenervation is this issue of disability-related changes in muscle. So we know that over time, people that have, the more impaired you are, and the longer the disability or the impairment lasts, the more likely that you're going to have changes, rheologic changes in your muscle. Even though you have a brain or a spinal cord disorder, there's an effect in the muscle, and the muscle becomes abnormal secondarily. So this is a MRI of these are identical twins, same age, same size. The patients weigh the same. And they both have cerebral palsy. If haven't done your PEDS rotation yet, gross motor functional classification scale is a scale that we use to evaluate impairment in children with cerebral palsy. And for kids with GMFCS 1 level, they can walk and run. They have essentially no functional impairments, but they still have cerebral palsy. And GMFCS 3 is a patient that uses some type of assistive device to walk, like a walker or a cane, and usually used as AFOs. So this is an MRI image of these twins. They both have PVL. The twin with GMFCS3 has more severe PVL, but the most important thing to look at here is we're measuring the thickness of the soleus muscle in those two twins that are the same size, right? But the twin that's more impaired, the muscle is about half the size of his unimpaired sibling. So if you're targeting, because the patients have the same size limbs, and you're targeting under EMG at the same depth for both patients, in one patient you're going to be in one muscle, and another patient you're going to be in another muscle, because you can't estimate the depth based on this atrophy. You also will see when you start doing ultrasound is that you'll see these sonoacoustic appearance in the muscle. You saw that in the patient with muscular dystrophy, where the muscle, instead of having this normal appearance of sort of mixed hyperechoic and hypoechoic, in other words, dark or light appearance, almost like the cut end of a broom in short axis, the muscle will become white. And the whiter the muscle is, the higher the echo content. That means there's been fibrofatty replacement of the muscle, the contractile elements. And that appearance may change what you inject, how much you inject, and whether you target that muscle. So that's another thing that ultrasound helps you with. So you can quickly isolate things that are hard to isolate. For instance, people sometimes are worried about injecting the iliopsoas muscle because of adjacent vascular structures. But this sonoacoustic appearance, the residents and I are going to work together next week on these images and do some live scanning. But this is this appearance of the femoral head, and sitting right on top of the femoral head is the iliopsoas. Medial to it is the neurovascular structures. You've got the rectus femoris and the sartorius muscle right here. And you can just pop through in most patients with a 30-gauge 1-inch needle to get these injections done. It's relatively painless because you can use a very small needle. Because you can see the muscle, you can see what the depth is. And this is in an adult patient, so you can see how superficial the muscle is here at this point. Same thing, tibialis posterior, and I have a video of this for later. In a short axis view, you can see the end of the medial gastroc, the soleus, and then in between the tibia and the fibula sits the tibialis posterior. We tend to name all of our images, like the FCR is the nose muscle. Here, this is the bathtub muscle. Looks a little like a bathtub, right? And the tib posterior sits in the bathtub. It's trying to get you to remember what these things are. But you can see, you can walk yourself down just from superficial to deep. And if you're going to inject gastroc, soleus, and tibialis posterior, you can inject all three with a single needle penetration. So you inject the gastroc superficially, then go to the soleus, and then go to tib posterior, and you save the patient 3 or 4 sticks, which most of our pediatric patients, even the adult patients, appreciate. Most people don't like being stuck. What about anatomic variations? We know that there are a lot of anatomic variations, particularly in the upper limb. Whether muscle is either present, where its location is in our patients with disabilities, the anatomic rearrangements that occur as a result of long-standing spasticity. And the ultrasound really does help you. Here's another image here. This is the flexor carpi radialis. Remember that nose muscle that we're talking about? There's the nose muscle here. But I want you to look at medial to the FCR in this patient is a palmaris longus muscle, but in this patient there is no palmaris longus muscle, so this is all flexor digitorum superficialis because the palmaris longus is absent. And the presence or absence of that muscle can again lead to targeting errors, which can be a problem. So in this next slide, it really does, this is the same set of images here, but here's flexor carpi radialis. And this is all flexor digitorum superficialis, and what we know is that up in this corner right here is the fascicle to FDS4. It always is in this position. 5 tends to be down here. But again, if you don't realize the patient has an absent palmaris, or if you're trying to target FDS and you don't know that the patient has a palmaris, you're likely to have a targeting error. And I treat a lot of patients with focal hand dystonia, musicians, violinists, pianists, guitarists, who you're trying to be very, very precise in injecting only FDS to D4 or only FDP to D2. And if you're off by a millimeter, you're going to be in the wrong fascicle, and you're going to cause this patient to be more disabled than they currently are. First of all, you're not going to make their focal dystonia better, and you're going to give them weakness in the wrong muscle. So it's a problem with this targeting issue. And you can see that there's lots of options. With ultrasound, you can determine how big is the, for instance, here, this is palmaris in this patient. This is the size of the palmaris in this person. So the size variation is huge. And in a patient, let's say you've got a patient with spasticity that has a large palmaris longus and has wrist flexion spasticity, you might actually want to target that muscle because it may likely be contributing to the patient's flexed wrist posture. But you aren't going to know if they have a large palmaris longus unless you have ultrasound images. So again, an added benefit. What about structures, this issues of structures to be avoided? Before I used ultrasound, I knew when I was doing neck injections and I was doing sternocleidomastoid, I knew the carotid artery was there. And I knew that when I was doing scalene injections that the lung was near where I was going. But it really gives you pause once you start doing ultrasound imaging, because if you look here, you see these three large hypoechoic circular structures that look kind of like vessels if you're looking at images. But when we turn Doppler on that image, these are actually the trunks of the brachial plexus. And this is the anterior scalene, this is the middle scalene, and running right in the fascial plane of the anterior scalene muscle is the phrenic nerve. So if you target, and it's right here, where that arrow is there, and this is anterior scalene here. So not only do you have to miss the lungs and the brachial plexus, but you need to miss the phrenic nerve, the vagus nerve, the suprascapular nerve, all of which are exiting in this region when we're doing these injections in the neck. And we're doing levator scapulae, longissimus capitis, we're doing all of these neck injections. And if you don't have ultrasound, you know where these structures are. And the only time we've ever had at the NIH movement disorders training protocol, the injection training protocol that I do, the only time that we've had a pneumothorax in a patient with a middle scalene injection was a patient that was not injected under ultrasound. So we now will not inject scalene muscles unless we have ultrasound. Because it was a very mild pneumothorax. The patient was not really very symptomatic, but we had to admit her to the hospital. We had to file a protocol deviation. The patient has 3 little kids. She wasn't really happy staying overnight in the hospital. The IRB wasn't very happy. Nobody was happy. So we try to avoid this. So what about, I said, I have to continue my structures to be avoided. There are certain muscles that I would consider high risk. And the scalenes are one of them. The other is the sternocleidomastoid. So here we've got a view here. This is a short axis view of the anterior neck. This is the sternocleidomastoid. And you've got the jugular carotid trachea is here. So this is the same view, but it's going to be a video. And I always have to say before I show this video, I was holding the ultrasound transducer. It was at a training program when I was training people to do ultrasound. And the attending that was there doing the injections does EMG guidance. And they didn't want the ultrasound because they don't do it, and they didn't want the patient to have ultrasound because they didn't want the patient to then ask why they weren't getting ultrasound when they came back to the next time. But I said, well, look, these people all came to see the ultrasound guidance, so you at least just have to let me hold the transducer, and this is what happened, hopefully. So here is, again, sternocleidomastoid. This is, I think that pulsating thing you can agree is the carotid artery. And there's the needle in the carotid artery. Because they went right through, and I was able to redirect them to this portion of the SCM that's away from the carotid artery. So let's play that again, right? So here is the needle going in. All right. So what's the problem with that? Well, the first problem is you weren't trying to do a carotid stick, right? I was able to say, okay, and I was in front of a group of about 100 people. when this happened. And so I just put my hand on the physician's hand. I said, could you just pull the needle out? And they sort of looked at me. I said, just pull it out. We're just going to do that again. And I put him in a different place, and we injected over in this portion of the SCM, which the carotid's over here. Now you're here in this part of the SCM. There's no vessel there, right? So what happened in this situation? What happened was, this is a patient with cervical dystonia that's been injected multiple times. And I think that the attending was correct in the position of the needle for either 1 or 2 injections ago. But when you inject toxin, the toxin causes the muscle to atrophy. So the muscle is now thinner than it was 2 injections ago, and you needed to change the depth of target to avoid the carotid artery. And you can't appreciate how much atrophy you get without direct imaging of ultrasound. Well, the other question is then, well, what's the problem of, if you did inject the toxin in the carotid artery, right? Well, certainly that wasn't your target. And we know that toxin spreads centrally, right? I mean, there's no question about that. When you inject peripherally, it's absorbed into nerves and it migrates proximally. But you weren't trying to, get toxin to go in the carotid artery. So more importantly, if you injected, if theoretically the person would have aspirated before they injected, but I see people all the time that inject without aspirating. So if they'd injected, probably there would have been no effect. But more importantly, there would have been no effect. So the patient comes back 6 weeks later and says, I got no benefit from these injections. Didn't work at all. So you say, well, okay, when you come back in 6 weeks, I'm going to increase the dose in the SCM because obviously we need to increase the dose. Well, you didn't need to, so you increase the dose, and now the patient has dysphagia and neck weakness because they didn't really need an increased dose. They needed the muscle to be targeted correctly, right? So that's the biggest problem, is if you have a targeting error, you think you're in one muscle, you're in another muscle, and you keep increasing the dose, you're going to cause weakness, and that's really the problem. Besides the fact that you don't want to stick needles in carotid arteries, or you don't want to give somebody a stinger when you do a scalene injection, which has happened. Even with ultrasound, you have to be very careful in some very thin females who have very thin, long necks that are kind of gracile. The muscle and the nerve are right next to each other, and you have to be careful. So for rehab docs, particularly for us as rehab docs, another thing that ultrasound helps me with is this issue of multiple approaches to the same muscle. So for the tibialis posterior, the typical approach that most people do is the medial anterior approach. And this is the tibia here, this is the skin, this is actually the medial head of the gastroc and the soleus over here. And you can see how far anterior the soleus and the medial gastroc actually run. But this muscle right here, this little triangular shaped muscle, is the FDS. And lying just deep to it, that little white line there is the fascial plane between the FDS and the tib posterior. So you can come straight down here. And if you may be injecting FDS and FDP and tib posterior, if you're injecting both, you just do first the FDP, FDL, sorry, there's so many Fs, flexor digitorum longus, and then just go deep to get the tibialis posterior if the patient also has toe flexion and you think that needs to be injected. But what about the patient? This patient weighs 220 pounds. You don't have a Hoyer lift for whatever reason. They're sitting in the wheelchair. The patient had spinal cord injury. They will not let you transfer them out of their wheelchair, because you are not their aide, and you are not going to get them back in the wheelchair correctly. And they're going to have to sit there for 6 more hours in the wrong position because you can't get them in the position correctly. But you need to inject their tib posterior. So you can have the patient sitting in the wheelchair. This is an anterior approach. This is tibialis anterior. This is extensor digitorum longus. This is the interosseous membrane out here, the intertibial artery. And just below the interosseous membrane is tib posterior. So you can just come down through the tibialis anterior when the patient's sitting in the wheelchair. You don't have to transfer them. You can get right in, and you can miss the intertibial artery, which you don't really want to penetrate going through, because you don't really want that leaking. Most of these patients are on anticoagulants, and you don't want them to bleed. You can't compress this vessel, if you stick through it. So this is another approach to doing it. And then here's this posterior approach. You've already seen the bathtub view. I choose these approaches depending on what other muscles I'm injecting. So if I'm injecting the flexor digitorum longus, I'm going to use this approach. If I'm going to be injecting tibialis anterior and posterior because they're both causing inversion, then I'm going to use this approach. If I'm doing the soleus and tib posterior, I'm going to use that approach. So it gives you multiple approaches. In our patients with movement disorders or in patients with, let's see if this is going to play here. This was a video, yeah. So this is an isolation of individual fascicles of this is somebody practicing on me. That's why I keep grabbing the transducer. Those of you that have worked with me will know I grab transducers from people. But you can isolate these individual, let's see if I can get this to play again. This may not be the best view, but you can have, dynamically, you can have the patient moving the muscle, or you can do this passively and just look for movement of individual fascicles and target that. So if you have a patient with spasticity who has D4 and 5 flexion more than D2 and 3, you can target those fascicles more easily using ultrasound. It doesn't take as long. You can do this with EMG as well, or E-stim. It just, you have to use, it takes a little longer with those techniques. And other targeting techniques, we now have an approval for botulinum toxin, for incobotulinum toxin A for sialuria. And sialuria, the salivary glands can't be identified with EMG or E-stim. You can use anatomic guidance, and actually the labeling study for incobotulinum toxin A or Xeomin actually showed that anatomic guidance and ultrasound guidance were both effective in localizing the salivary glands. But I find it really useful to avoid vessels because these structures are highly vascular, and you can also avoid the parotid duct, which sits sort of right in the middle of the parotid gland. So I think that they're pretty easily. It's a nice technique when you're doing these guidance for salivary glands to use ultrasound. And you can also visualize this is a long axis view of sorry, I'm using my arrow again. This is a long axis view of the sternocleidomastoid as opposed to that short axis view we've been looking at before. Carotid and jugular are down here. This is proximal, this is distal. That right there is the needle in plane. So it's the long axis view of the needle in the SCM. And what you can see is you can actually see the toxin as it's injected, and you can see the diffusion and spread of the toxin, and it has changed my injection pattern so that I don't over-inject at one site. Because if you inject too much toxin at one site, the fascial planes of that muscle are not toxin tight. If you put the muscle under a lot of pressure, the toxin is more likely to escape into adjacent structures. So it's changed how we inject. And what about other applications? So I do a lot of diagnostic nerve blocks prior to doing toxin injections. It's a patient that you don't know whether, is this a contracture, is this severe spasticity or dystonia, and you don't really want to do toxin injections, which are going to cost a couple $1,000s if the patient has a contracture. So you can do a nerve block. So this is a isolation right there. I'm going to try to pause this there. And this may be asking a lot for you guys to see this, but this circular structure right there, it's got sort of a honeycomb appearance. You'll have to squint and believe me. That's the tibial and fibular nerves together before they split at the popliteal fossa. But nerve has this honeycomb appearance, and you can identify the posterior tibial nerve, and you can follow it. Now the fibular nerve is moving off to the side here, but you can track the posterior tibial nerve down, and you can do either, this is the needle coming in, and you can see the stem. We were doing a diagnostic block, and this is actually injectate going in to surround the nerve. So for diagnostic block, it's really great. You can do this block. It lasts for an hour or two. It also, if you do motor point blocks, you can kind of give the patient a test drive of what spasticity, reducing their spasticity would be like. Instead of doing a nerve block, you do a motor point block. You go into the muscle and isolate little motor points. You can give them a bit of a test drive of the toxin or phenol, more likely that I would do it for phenol than toxin. And it really allows patients to decide, do they really want to do this more permanent procedure. Now, I use, as you noticed from that picture or that video, I use electrical stimulation and ultrasound for nerve blocks. And for motor point blocks as well. Now, with the current transducer technology that we have, we can't visualize motor end plates, but you can see this microstimulation in the muscle. So we isolate. When I say I use ultrasound, it doesn't mean that I don't use EMG and I don't use E-stim as well. I use ultrasound plus EMG for almost all of our cervical injections in patients with cervical dystonia, because ultrasound tells you where you are. The EMG tells you, is that muscle actually contributing to this patient's posture? Their head is in this position. Multiple muscles can be causing that posture. And the EMG tells you, is that muscle really actually contributing to the patient's posture? So these are not mutually exclusive techniques. So what about for phenol injections? So this is, I'll try to pause this. This is superficial. This is the adductor longus, and then brevis is here, and magnus is below. The obturator nerve, the anterior branch, runs in the fascial plane between the longus and the brevis, and the posterior branch runs between the longus and the magnus. So you can use EMG or E-stim plus ultrasound, and it speeds the process. But you can see the stim, the needle is right here targeting the fascial plane where this is running. And this is more right on the nerve at this point. And there's the stimulation and the injectate going in as well. So what it does is, when you're using E-stim combined with ultrasound, is it reduces the stim time, on time of the stim procedure, and reduces the volume of the injectate. It's been shown in a number of studies that it reduces the volume of phenol that you have to use, and then potentially reduces adverse effects for this, and potentially paresthesias. So sort of my summary here, and I'll show hopefully a couple of videos here. I don't know if these are going to be, yeah. So this is here's that bathtub view. You guys are getting used to seeing that now. A posterior calf, superficial. This is transverse view here. And I'm using an out-of-plane walk-down technique. And you don't really see the needle, but you can see the tissue moving as we go from superficial to deep into the tib posterior. And then once you're in there, we sort of perturbate the needle a little bit. You can see the injectate, how much is blowing up the tib posterior just by injecting that small amount of volume. And this is, I think this is it. Oh, sorry, this is the OR. This is a patient in the OR. We're doing, I thought I got rid of the sound. Sorry about that. This is the flexor carpi radialis. I don't think that one's going to show very well. I was in Germany doing that, so it might be in German, not in English. But so that's sort of the end of my my talk, is to say that I hope that I gave you an idea of what incorporating ultrasound into your practice as a neuro-rehab doc can do. Is that it's not just exclusively for procedural guidance. It really does provide added benefit as a part of your physical exam. And sort of an extension of this I didn't put into this talk was this issue of using quantitative measures of ultrasound, because most people think of ultrasound as a qualitative measure, but in research we're actually using quantitative ultrasound measures to measure changes in muscle. We've got a couple of studies that we're doing when patients are either getting gene therapy or other interventions, and we're trying to track in neurodegenerative conditions to try to track whether or not there are changes in the muscle over time. And one of those techniques is a technique called elastography that looks at muscle stiffness. Another is a quantitative measure of echo texture of the muscle. And there are ways, rather than just sort of subjectively saying the muscle is either too wide or not wide enough, you can actually look at quantitative speckle analysis of the muscle. So there are quantitative measures in a research way as well. And I hope that you agree that there are some benefits from a procedural standpoint as far as safety, accuracy, speed, comfort, and efficacy. And I'm hoping that maybe I'll spur some of you guys into thinking about incorporating ultrasound into your practice. And I'll stop there and take questions.
I have two questions. Number one, do you think it's beneficial to use like the Hackback scale to
Yeah.
quantify your
I do. I do use HECMAT scale. So HECMAT scale is a published scale from a number of years ago. It's used both in the neuromuscular and in the it was devised for muscle diseases, primary muscle diseases, but we use it a lot in patients with upper motor neuron syndromes as well. So yes, I use it on a fairly regular basis. And change if they have a 4, which is, the muscle is whited out essentially, and you can't discriminate the fascial planes between individual muscles, then I'm going to probably use ultrasound plus EMG and listen to the EMG activity of that muscle as well to determine, should I really even inject that muscle, or is the muscle just so fibrotic that it's not contracting? But that's where EMG may help you in addition to the ultrasound. Yeah.
Okay.
Yeah.
The second question was, alone or a combo, is there any, what would you say is the most superior form?
Say that again.
Being used alone or a combo with ultrasound, would you say ultrasound with EMG, ultrasound with E-stem, or ultrasound alone is equal or superior to other methods?
For limb injections, for virtually all the limb injections that I do ultrasound alone. I train residents and fellows, though, and I'm training them to do all the techniques. So for the residents and fellows, we oftentimes are doing both, but if I'm doing it by myself, I do only ultrasound. And once the residents or fellows are proficient in all the techniques, I let them choose whether they want to do both or one. And most people will choose only to do ultrasound because you can use, rather than using the Teflon-coated monopolar injection needles that you have to use for E-stim or EMG, those needles, if anybody that injects, they're hard to get through the skin. They hurt more to inject. You think with Teflon on them they would slide through the skin, but they don't. They're thicker. The gauge of the needle is whatever it says it is, but the Teflon makes the gauge bigger. So it hurts more to get those through. And not a commercial, this is not a commercial message, but I've found that the Ambu needles hurt less than that, for instance, Botox makes needles that you can buy, but the Ambu needles seem to insert better. So with ultrasound alone, I just use hypodermic needles, and the vast majority of the injections I'm doing for upper limb, even in an adult, I'm using the 30-gauge 1-inch needle. And the patients, a lot of times, don't even feel it. Or I use a 27 1.5-inch needle, hypodermic. And for deep-seated pelvic muscles that I can't get with one of those, I use a 25-gauge 2.5-inch spinal needle. And they insert so much better than those EMG needles. So when I use the combination of EMG and E-stim, or EMG and ultrasound, as I already alluded to, is for cervical muscles, almost always, I would say 80% of the time, I use that combination. And the only time I use E-stim is if I'm doing nerve blocks, because patients don't like it. And if you have kids, you have to put them to sleep to do E-stim. You heard that E-stim and the EM. I was doing the flexocarpy radialis. You could hear the OR stuff because the kid had to be asleep because we were doing phenol injections in the adductors, and we had to do E-stim, and we had to put the kid to sleep. So that's sort of my practice. Other people do E-stim and EMG, or E-stim and EMG plus ultrasound all the time for everything. It's your choice. Right. Any other questions? Okay.
Do you incorporate hydrodissection into your practice often, or is it more a complement when you see referral?
I do it a fair amount for peripheral nerve hydrodissection because that's what I'm seeing a lot of. And so, yeah, I would, it depends on what you mean by a lot, but I do a fair amount of peripheral nerve hydrodissection.
And is it usually like D50 or?
I'm typically using just saline because that's what I've got access to. It's everything that I do is under a research protocol, and that would require a protocol amendment. So it's just it, and the saline works. So.
Do you find that patients get lasting relief? Or
Yes. Yeah. Many do. It depends. You have to choose your patient, and you have to choose the problem. But when we're using it as patients that are not operative candidates, or in our research protocols, because of the protocol, it would break protocol for them to have a surgical procedure. But I can do the hydrodissection is allowed, but having the patient have a surgical procedure, it would get them out of let's say an NCI protocol, and they're getting a study drug that they're benefiting from, and they've got this peripheral nerve entrapment, and I don't want them to get kicked out of the study. So that's when I'm doing, and my applications are odd, you know, because patients are all under other protocols. Yeah. Thank you.
Trying to make sure the mic is off.
Yeah, here, I'll come over here. Before I steal your the current study, so the current studies show that in the multi-center study right now, there are a number of studies that show, all the studies have shown that any instrumentalized therapy and antidepressants. There have been a number of studies, but not large. I was thinking maybe we're doing but not large controlled trials. And that's why we're doing a multi-center trial to look at that. Is patient preference, time of the procedure, its effect on the is there an e-stem, you know, it's a crossover design to look at patients doing e-stem so we're trying to see, which one is better. I grew up speaking in class about eye, and now it's not quite the same. Did you?
Just want to say thank you.
Yes.
It's great to meet you in person through Steve and Rich Katz. I always hear you on Zoom.